Hi, I'm Tammy Potter, and welcome to the Pregnancy Process Podcast, a show designed to help you navigate the hugely transformative journey to motherhood, where you'll hear the unique experience of experts in this area and the incredible stories of women sharing their conception, pregnancy, and postnatal journeys so that you can have a healthier, more informed pregnancy. In today's episode, I talk to renowned obstetrician and gynecologist Dr. Violet Kieu. Dr. Kieu holds a prestigious subspecialty qualification in reproductive endocrinology and infertility, a credential achieved by fewer than 80 specialists across Australia and New Zealand. As clinical director at Melbourne IVF, she is a passionate educator for both men's and women's health and fertility. In this thought-provoking episode, Dr. Kieu helps shed light on the complexities of endometriosis as we explore the root causes, diagnostic journey, and cutting-edge management strategies. Dr. Kieu leaves no stone unturned as she unravels the intricate relationship between endometriosis and fertility, offering invaluable insights and practical strategies tailored to each woman's unique goals and circumstances. Whether you're battling debilitating pain or navigating the challenges of starting a family, this episode promises to be a game changer. So if you or someone you know is among the 1 in 10 women of reproductive age affected by endometriosis, this podcast episode is absolutely for you. So get ready to be equipped with the knowledge to help take control of your health and well-being. Dr. Kieu, thank you so much for your time today. It's fantastic to have you here with us.
Thank you so much for having me. It's my absolute delight.
And your specialty is so deep and also so wide. You've spent so long, you've dedicated your entire life to working in women's health and in fertility health. So I'm very excited to talk to you around something that I know affects so many women, especially when it comes to their fertility and conception journey. So if it's okay with you, I'd quite like to start with the basics around endometriosis, the kind of what is endometriosis and whether or not we even know what the cause of it even is, because I know it affects so many women.
Yeah, again, thank you so much for having me here. It is an absolute privilege to be able to talk about women's health issues and particularly to educate, advocate, and talk about these issues to make it at the forefront of people's minds. So specifically today, endometriosis. What is it? It's a chronic inflammatory condition where there are cells that are similar to the cells inside the lining of the uterus, the endometrium, that are outside of the uterus. And those cells can deposit anywhere, predominantly in the pelvis. So we can have endometriosis in the lining or peritoneum of the abdomen pelvis, but also endometriosis can impact the tubes and the ovaries and overall impact fertility. And not just fertility, can be a cause of pain. In terms of stats, well, there's so many stats, but some key numbers to think of include about 10%. So 1 in 10 women of reproductive age has endometriosis. That of those who have endometriosis, studies vary, but one could say around 30%, so 1 in 3 women with endometriosis may have issues with infertility. That of women, if you flip it the other way, of women who present with infertility, some studies have shown up to 50% of those women have endometriosis. And also, if you look at a chronic pelvic pain population, up to 70% of those women have endometriosis. Endometriosis can present widely and differently. Now, you've asked a very good question as well. What may cause it? There are different theories, but one of the predominant theories is Sampson's theory, and that's a retrograde or backwards menstruation. So in a usual or typical period, the lining will shed on a cyclical monthly basis and the blood will flow out In endometriosis, there is a thought that the blood or some blood might flow backwards up the tubes and deposit in the pelvis. And there are theories again of tissue injury and repair. So therefore, the more periods that you have, these inflammatory cells cause and have like reactive oxygen stress, and they cause inflammation and then cause scarring. And that process of tissue injury and repair might mean that your tubes get blocked, your ovaries form chocolate cysts or endometriomas, which then affect your egg quality, your egg number. And certainly by having these inflammatory cells at the cellular level, but then this scarring on top of that, which might cause bowel adhesions, uterine adhesions, whatnot, then you get a process of pain. That's the predominant theory. There are other theories of cellular changes. Maybe there are cells that in the pelvis that undergo a change to become like endometrial cells, and other cells such as, that's another theory, but not the predominant one.
Those statistics are quite scary, really, when you think about it. And it is affecting so many women. And when you talk about all of the things that it can impact, it's no wonder that there are women experiencing fertility issues around that. And in terms of, I have a question around the statistics and how many women are experiencing it. It seems to be that it really is on the increase. Now, is that because we're just getting better at diagnosing it now, or is it actually on the increase? Or do you think it could be a combination of both?
I think anything statistical has a component of being multifactorial. And I think what's really important now is the public health messaging. And there are strong, both from the government support websites such as yourfertility.com.au, or even patient advocacy groups such as, say, Endometriosis Australia. So really having first awareness that endometriosis exists. Secondly, that what gets recorded gets to be important, and certainly education on the patient level and on the general practitioner doctor level, allied health specialist, obstetrician gynecologist and fertility specialist level makes the change in terms of increased number of diagnosis, presentation, awareness. I would have to pause and say, to really talk about if they're increasing incidence over time, that's something we would have to look very clearly at the data. But what I would say is that there's increased pickup because of the great work around advocacy.
So in terms of that, are there any common risk factors that we know of when it comes to endometriosis? Are there lifestyle factors? Are there hereditary factors? Are there any commonalities that we're discovering in the research around endometriosis?
So what's important to know is that the most recent endometriosis guidelines were the European guidelines. And we do know that endometriosis, again, can be multifactorial. So women in families with endometriosis, it's important to ask a family history as well as a personal history. In terms of endometriosis itself, what's important is an early diagnosis. So that could be a game changer because there are different ways of managing the impact in a woman's life. And that can be, as you suggest, lifestyle factors. And in the guidelines, there's no one modality which is recommended above others, but it's noted that allied and complementary health can certainly help with a woman's ability to manage her symptoms. Now, I've talked about symptoms generally, but with endometriosis, symptoms can be asymptomatic. People might have no pain symptoms at all and might have no fertility issues at all, or sometimes the only time an investigation for endometriosis is done once they have found that they are having problems trying to conceive. In terms of symptoms, pain is the major one. And there are classically 4 types of pain. Pain with period, that is a few days before at the time of bleeding, opening bowels, pain with passing urine, and even pain with intercourse. In terms, they are more specific pelvic type symptoms. We do know that endometriosis is complex, and it's not just the inflammation of the pelvis, but it also is sensitization of nerves. So if people have chronic endometriosis, their nerve pathways to their brain may have more nondescript or general, such as fatigue. Someone with endometriosis certainly might actually have fatigue, and that impacts on their quality of life, their ability to function in their personal lives, or also in their professional lives. So it's very important that we take a thorough history personally and on impact of life, as well as a family history. In terms of things that might improve, so the things with endometriosis is making the diagnosis, being aware, seeking help from your GP, fertility specialist, obstetrician, gynecologist. That's number one. Number two is having a team that, once a diagnosis has been made, knows how to help manage. And a diagnosis is, again, you can do a symptom diary. So all those things I mentioned, and just write them down so that it's in a timed manner. And also investigations can be ultrasound or history examination, but then ultrasound, even an MRI to have a look at the pelvis. And the classic, but not essential now, if we can find endometriosis on imaging, is surgery, which is the laparoscopic keyhole surgery, and to take biopsies of lesions of endometriosis. Now, let's say either a laparoscopy has been done or not done. We can even treat endometriosis empirically, or we're suspicious from a medical point of view that this sounds and behaves like endometriosis. The management, as mentioned, can be allied health, but also medical, including non-hormonal and hormonal. So non-hormonal could be non-steroidal anti-inflammatory medication that you can buy over the counter in conjunction with your pharmacist. But also the hormonal ones include the oral contraceptive pill or progesterone-only preparations, such as the progesterone-only pill or other long-acting reversible contraceptives, such as LARCs, such as your Implanon in your arm or leg, or your Mirena inside your uterus. And so those are the main modalities of treatment, up to then including surgical excision. There are lots of different talks about how to manage it, but truly medical and surgical are the higher end treatment options.
So you've gone through a lot there, and I would just, because it's starting from just your symptoms, you've mentioned the fatigue side of things, and I think that's something that I'm going to put a little pin in, because I'd like to come back to that, because I feel like that symptom of fatigue is something that so many women feel, but it's so hard to pinpoint what's actually causing it. So I think I'm going to come back to that, because I feel like fatigue is something that needs to be discussed. You've talked about the 4 types of pain that you might experience. You've talked about the fatigue. Now, what kind of level of these symptoms would you say that they indicate that you need to look into this further? Are there multiple layers of this? So if you're experiencing pain with when you urinate, pain when you have your periods, would that two combination, and you've got some fatigue, would those two combinations say, hey, I need to look into this further? Because I feel like, especially with women, sometimes we all lead really busy lives, and I think not everyone's really good at following up on things, being like, oh, like my cycle, I'm getting pain with my cycle, I should probably look into that. How would you recommend women look out for symptoms that would indicate further investigation?
Yeah, I think a person should be their own best advocate. And if it is bothersome, if it is something that's on your mind, or the symptoms impact your ability to live your normal life, so your quality of life, there is no prescriptive or didactic or dot point, 3 symptoms of this, 4 symptoms of that, you must go get a diagnosis. No, it is more because it is a spectrum of disease. From it can be, again, as mentioned, asymptomatic, no symptoms on your life, to lying in bed at home, unable to go to work, in severe pain. So once it is something that you think that there is something, that there is a question mark, seek advice, and working with a health professional can help tease out a diagnosis, or it could lead to looking at other things that could be differential diagnosis as well. So for example, chronic pelvic pain, there's all other causes as well, musculoskeletal, urinary, bowel disease. So if you have a symptom, I think generally don't ignore things. Yeah.
I think that's very good advice. And in terms of the diagnosis process, you have mentioned some of the ways that this can be managed. What
Mm,
would that diagnosis process look like? Because there is like ultrasounds and MRIs and you potentially going into surgery and then
mm,
looking at management of it. Let's say I came to you and I
mm.
said that I've been experiencing these types of 4 pains and it is impacting my quality of life. How would you then walk me through that diagnosis process? What would
Yeah,
that look like?
absolutely. So I'm a subspecialist, CREI, highest level fertility specialist. So endometriosis has two major presentations, pain and infertility. So the women who come to see me are more on the infertility side. And that is, so again, I'll put a pin on that and we'll talk about fertility, potentially egg freezing around endometriosis. But in terms of a pain diagnosis, again, like seeing your general practitioner or gynecologist, there's a very clear pattern of clear history taking about yourself, your work, the impact on your life, your gynecological history when you first had your period, how your periods have been, how heavy, what, if any, contraception you have tried or not tried, hormonal or otherwise, any pregnancies, those outcomes of those pregnancies, other medical history, other medical conditions, medications, or drugs, or even recreational drugs that you take. Have a look at, I'm going to say, your weight and height. And even though BMI is a crude measurement, just note that as well as part of our history and examination, and then do a general physical examination, up to including a pelvic examination with consent, right? And then if the medical thought process is that there might be endometriosis, to organise a pelvic ultrasound and a good quality pelvic ultrasound, because some of the signs on ultrasound might be subtle. And there are different degrees of people who are trained in ultrasound. You might have a general radiology company, and that's great, but there's also women specific ultrasounds, and some obstetricians and gynecologists do an extra certification called COGU in obstetrics and gynae ultrasound to really look particularly at DIE or deep infiltrating endometriosis, to look if there are nodules on certain ligaments, such as what we call the ureterosacral ligaments, or if there are nodules in the ovaries affecting the tubes, supporting the uterus how it sits because of the scarring and tilts. And then MRI is more emerging technique of looking at endometriosis, but really a high quality women's ultrasound. Even if we see endometriosis, that in the international guidelines is now enough to say you have endometriosis. But if you flip it, if it doesn't show endometriosis, you still might have early or subtle lesions. It doesn't mean you don't have it. And therefore, I would say to you or to a patient, if we've got endometriosis, we've got a diagnosis, here is management, lifestyle. If you are not intending to get pregnant, we could talk about hormonal therapies and pros and cons of that as well, and or at what point we might recommend surgery, knowing that the first surgery is the best surgery, where you don't want to be in a pattern generally of repeat surgery. So have to really talk about the pros, cons, risk, alternatives of what you're trying to achieve. So that's sort of pain management. But if you come to me with endometriosis or not knowing you had endometriosis, and in a fertility point of view, we would have to think about your goals of care. Have you come to me for egg freezing and we found this? Or have you come with, say, for example, in a heterosexual couple trying for 6, 12 months and not falling pregnant? Now I have this whole other pathway of looking at all these different female and male factors, and up to and including an ultrasound to test the openness of your tube, so to see if the scarring of endometriosis has affected your tubal factor. Also look at your egg number through a blood test called anti-Müllerian hormone. We can talk about that as well. And also looking at, again, if you do have a male partner, male semen quality. So how endometriosis is managed in a nutshell is individualized on your presenting problems, your goals of care, also what your preferences are, what you've tried in the past. And the gold standard for endometriosis care is actually interdisciplinary. I've mentioned general practitioners, I've mentioned obstetric gynecologists, fertility specialists, But that's just one aspect. There is certainly a whole aspect of ongoing management of this chronic condition, chronic inflammatory condition, and these endometriosis centres of excellence do have allied health pelvic physio in terms of pelvic exercises, as well as psychologists and psychological support for how this may impact the fatigue or other symptoms on your day-to-day existence.
That's incredible, isn't it? That there are these centers out there to help with all those types of things, because things like endometriosis would impact your entire life across the board. And especially for those, and I'd like to talk about the fertility side of it now, because I feel for those who are going through their fertility and conception or their conception journey, and they're facing things like unexplained infertility, where they have been trying for some time, I think actually looking down this path and realizing that you've got an inflammatory disease like endometriosis that can affect your fertility chances or your conception chances, that would affect them mentally. It would definitely have a mental impact on them. So you've mentioned so many things already when it comes to fertility and endometriosis, altering the chances of conception. You've got the altered hormonal and immune function when it comes, or immune function when it comes to endometriosis. You've got inflammation, you've got blockages, you've mentioned anatomical issues, all the way through to impaired egg quality. Are there any specific areas of all of those that you'd like to go into more detail about when it comes to fertility and conception?
I'll talk about it broadly that endometriosis, these inflammatory cells, live in the pelvis, and it has been described as a toxic pelvis. So we do know that the ways to manage endometriosis and fertility are largely surgery, remove the deposits of endometriosis, and or assisted reproductive techniques such as intrauterine insemination, where we place sperm in at the right time, just around ovulation, all the way up to IVF, in vitro fertilization, where we actually give medication to women to grow more than one egg, remove those eggs outside of the toxic pelvis, give them a chance to fertilize with sperm outside, then replace the embryo inside the uterus for implantation. And there are other ways of thinking about, if we do create embryos outside, are there ways, though there's still debate over what's the best way? Is it helpful, for example, to try and suppress the endometriosis? In the past, that was done more commonly. Nowadays, the evidence is not as clear on that. And then where the evidence becomes quite unclear is, or actually there are different things to consider. And one of those situations is if you have endometriosis where you have blocked tubes, IVF can bypass the blocked tubes. That's probably the most common way, a clear answer to blocked tubes due to endometriosis, bypass them. But it becomes a little bit more complex when someone has endometriosis and they might even have deposits on their ovary, so the endometriomas. And it becomes even more complex if they have those deposits on both ovaries. So you think, okay, you've got these chocolate cysts, they're causing distension, they're probably causing pain. There's different theories. Their increased iron in the blood there might cause some impact on the surrounding eggs. Let's remove those endometriomas. But then the counter argument is, every time you do surgery, for example, removing endometriomas, you might inadvertently remove the other eggs in your egg reserve, or they might be bleeding, and then to stop the bleeding, which is very important, you might diathermy or burn away other eggs. So it's a true informed conversation that you need to have with someone when they come with infertility, and you discuss both surgery, so it's a complex discussion, or assisted reproduction such as IVF.
So it's like everything to do with the body and health and well-being and conception and fertility and pregnancy and postpartum. It is so individual, isn't it? So it is very difficult to give broad generalized information to something that is so specific to the individual. So in terms of managing endometriosis patients through the IVF process, can this then cause flare-ups with the IVF? Because you have mentioned suppressing it. Is that why the jury is out on that in terms of the research at the moment?
Well, the research has really shown that suppressing endometriosis before your IVF may not have the benefits that we thought it did. And if you flip it the other way, in the International Endometriosis or ESHRE guidelines, which is the European Society of Reproductive Endocrinology guidelines, there actually is no evidence, and this is good, that IVF, giving hormones to stimulate mature eggs for egg collection, there's no evidence that doing IVF worsens your long-term endometriosis over your life. So therefore, we think that there is strongly a role for IVF in endometriosis. What is actually emerging now, and research is looking at the role of endometriosis and egg freezing. So the guidelines state that there are pros and cons, but the true benefit is as yet unknown. So as a fertility specialist, I see many different types of people in different situations, single women, married couples that are heterosexual or otherwise, gay, lesbian, LGBTQI community as well. So we have managed patients with donor sperm, donor eggs, donor embryo, surrogacy, right? So everyone is different and their needs are different. But largely, if I had to break it down, I have egg freeze patients and I have fertility patients. Now, with egg freezing, really guidelines across the board say the most important number is your age, at what age you freeze eggs and how useful they are to you in the future. And guidelines, Australian, international, most medical use under the age of 35, but actually in some Spanish studies, the highest number of people who actually freeze their eggs are 35 to 39-year-old women. That's sort of the real world experience versus what's medically recommended. So yeah, it's not prescriptive, and I wouldn't block anyone from seeking more information about egg freezing based on their age. But how egg freezing might interplay with endometriosis is a woman might come just like wants to freeze eggs, and they find they have a low egg reserve. And why is that? So then I would, okay, well, there's different causes. So let's think family history. Has anyone had an early menopause? Any genetic diseases that run in families? So you're thinking about diseases or single gene diseases such as Fragile X, etc. And that's just a complex disease, but that can affect your egg number as reflected by the anti-Müllern hormone AMH. Do you have autoimmune diseases? Test your thyroid antibodies. Test your adrenal antibodies. Do you have metabolic disease? Do you have autoimmune diabetes? And then if they're all okay, then again, through the history, pain, how are your periods, etc. And truly endometriosis, again, we could see an endometrium on ultrasound, or we could see on ultrasound that they have deposits or nodules of endometriosis. And that is when we get to a situation, okay, well, we might have a reason for why your egg number is reduced, your ovary has these endometriomas. Let's now think what you want to do with this. This means that individualized, should we plan to egg freeze, but knowing that it might be a number of cycles to build up a pool of eggs for your future fertility? And what are the risks when we put a needle in the ovary? At all times, we have it under ultrasound. But if this endometriosis or endometrioma is blocking the way, what are the risks of infection? What are the risks of unable to collect your eggs? So we really have to factor in how endometriosis might affect a person's egg number, egg quality, and how we can make a strategy to overcome that. For example, banking more eggs.
And so can we talk about it in a fertility journey? Because that was incredible. Thank you so much. I was riveted to the screen there. Can we talk about it in a fertility perspective now? Because you've
Yes.
you've just blown my mind a little bit with that.
So let's say you have a heterosexual couple in their mid-30s, okay? Man, female. And then we've said that per the international guidelines, the management of endometriosis in fertility pretty much can't give hormones to suppress things because we're trying to have eggs. So we can't do that. And we can't suppress ovulation. So the options are surgery and or pretty much IVF. These are the major options, okay? So it is a individualized plan. What are the benefits? And particularly in unexplained infertility, where egg count. So infertility to have a baby, by and large, the three major factors. So this is very simplified. Ovulation, so you have eggs that mature, that you have open tubes and a uterus, and you have normal sperm. So these are the very basic building blocks. So we've done some investigation. Sperms quality's fine. We've got a normal number of eggs in the blood count, and we may have done a tubal study and the tubes are open. Egg tubes, sperm fine, no pregnancy, unexplained. Or is it endometriosis? Now, then, as mentioned, the options are we could do a diagnostic laparoscopy to have a look inside the abdomen. So that's a day case surgery. A woman goes to sleep, a thin camera the size of a pen, once the patient is fully anesthetized, through a cut in the belly button to have a systematic look at the pelvic side walls, around the bladder, at the uterus, under the bladder and between the bowel. That's called the pouch of Douglas. Look at the ovaries, look at the tubes, also have a look at the other abdominal organs, look at the liver, look at the stomach, look for adhesions, right? That's a diagnostic laparoscopy, and we might even instill some fluid inside the uterus, have a look through a hysteroscopy, another camera, pen camera inside the uterus, and put some fluid in to double check the tubes. Now, depending on what we find, we can find no endometriosis, or we can find a little or a lot. And the American Society of Reproductive Medicine has graded endometriosis into 4 stages, pretty much from mild to severe, 1, 2, 3, 4. And actually, the very clever colleagues and researchers and clinicians around the world have even come up with something called the Endometriosis Fertility Index, based upon a huge number of factors, but a patient's age and what's found at surgery can say how likely a person would fall pregnant after trying for 6, 12 more months. And if they don't score well on that, you might say this is actually scientific, the best humanly we can do. Given your older age, given the severe endo, probably it is best to have assisted reproduction. Actually, it is probably best to see how many eggs we can get and how many embryos we can help you with. That will shorten your time to pregnancy. That would be probably the best resource of your time, right? But if, let's say, you've done the endometriosis surgery, you found a few small nodules, you removed them, you've proved the tubes are open, and you're on the younger side of 35, it's not unreasonable for someone to say, you know what, might want to try for another 6 or so months, etc., and then reconsider the other options. And if we have proven, because not everyone with endometriosis is infertile, we have to remember that, okay? Yeah, so that's not an unreasonable strategy as well. In a mild endometriosis, certainly removing mild endometriosis can help with natural conception, noting normal sperm. But if it's severe endometriosis, it's a long duration of infertility. Honestly, therefore, these are reasons to consider your stronger interventions.
And even with the journey of assisted reproductive technology, there are varying degrees, as you've mentioned previously. You've got, this is your area, so I will try and remember off the top of my head.
Yeah.
But you've got like ovulation induction, you've got the process of injecting the sperm next to the egg. So if you were going through this and you weren't in that severe, you might want to try for another 6 to 12 months on your own, but then look at other assisted technologies. Did you want to touch on those? Because obviously this is not my area. I've kind of got a grasp around it. But
So the International Endometriosis Guidelines has over 100 recommendations. And unless you've got the document in front of you, I don't think anyone can remember them all. But what is of note is they do state that in mild endo IUI, intrauterine insemination, can be considered. So again, let's say you're 35 years old, you've experienced infertility with your male partner for 6 months, unexplained. We've done a laparoscopic surgery and we've removed just small deposits in your grade 1 or 2, very reasonable, 3 to 6 months. I wouldn't say 12 actually, 3 to 6 months trying spontaneously. And or just to increase the chance of fecundity, which is your chance of pregnancy per month, just a fancy word, just to increase that, we could suggest the intrauterine insemination. And when I say that, it's not just getting the sperm, concentrating, cleaning the sperm. It's also placing it through the cervix into the uterus, so bypassing any mucus, mechanical obstruction at the right time that we think that the egg will ovulate from the ovary, knowing that once the egg has literally burst out of the ovary, it only survives 12 to 24 hours. So we've got to optimize chances, get sperm in once it's just ovulated, or even the few days before, because we know sperm actually can survive 3 up to 5 days in the female reproductive tract. So it's about, well, I sound, it's location, 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 like an auctioneer, but time as well. And so to do that, we can use a combination of ovulation induction, which is where we track a woman's cycle and may give some gentle medications to strongly encourage 1 or 2 follicles to grow, and then put the sperm in at the right time. This is how I'd explain, say, intrauterine insemination. So any decision we make, we need to have planning. So that's medical consultations, nursing consultations, counselling consultations, okay? So I'm talking now that you've made your decision with all the information in an informed setting. Then generally an IUI cycle might run by you call on your day 1, first full flow bleeding. You call the nurses, and if you're spotting, you're not sure, call the nurses and they can just check in with you tomorrow and figure out which one was day 1. Not to worry if your bleeding pattern's a bit abnormal. That's a common question I get asked. So call with your day 1. And then, for example, by day 3, we might start some medication. And that might be a tablet, commonly letrozole, which is a tablet which just gently increases your own brain follicle stimulating hormone, because the brain works in conjunction with the ovaries to grow and mature eggs. And in a general cycle, a general period is 28 days, which is 4 weeks. So 2 weeks of egg growth, 2 weeks of lining maturation and implantation, if that were to occur. And if not, we bleed, it starts again. So day 1's the first day of bleeding. All the eggs are small. Your brain usually should just recruit a tiny egg, and after 2 weeks or 14 days, big egg ovulates. But just so that we can help a bit, on day 3, take for 5 days, this tablet letrozole increases your brain FSH just a touch, and you might grow 1 or 2 big eggs, and we'll scan you around day 8, day 10, just to have a look, make sure we can see the growing follicle. That's like a soft eggshell that houses or contains the growing egg on the inside. And we might even do some blood tests, make sure that this egg is metabolically active, because an ovary very cleverly makes 2 major things, makes a lot of things, but 2 major things are eggs and estrogen. So as this egg is growing, we might do blood tests just to track the estrogen, make sure it's within normal parameters. And then once the egg looks like a really good size, the lining of the uterus, nice thickness, we might even give a medication to trigger, to release that egg, and therefore we can time when we put in the sperm in the next day or 2. Or if the egg looks really, the follicle looks really good and the woman otherwise has a regular period, we could wait for her own natural LH, or luteinizing hormone, just another hormone in the brain, to cause that surge, and then time the sperm. And whilst I've talked about this in the context of intrauterine insemination, which I would recommend, if a woman simply wanted to track her period cycle, again, could do similar things so that we could tell people the best time to have intercourse. But generally around ovulation, and I would say on a 28-day cycle, if ovulation's around day 14, that week leading up to day 14, have intercourse a couple of times a week, maybe and once on the weekend. I really don't advise people to have sex every single day, because that's not usually maintainable, sustainable, etc. So we just have to be a bit strategic in how we best improve our chances of fertility.
That's incredible, isn't it? And I think just understanding that I feel like a lot of people, when they think about assisted reproductive technology, they do think egg freezing, or they think the full cycle IVF. There's that almost that little section in the middle that can be really helpful for those people that maybe don't need the full IVF treatment cycle and just need a little bit of a push in the right direction. So just understanding that for those who maybe are going through an endometriosis fertility journey, that maybe aren't on that severe end, there are treatment options available that will help them, that are maybe just that in-between stage. I
Yeah,
think that's great.
absolutely. Yeah, it just takes conversation to educate generally about endometriosis and fertility, but specifically what might be suitable for you as an individual. On that note, what I'd say is I usually do tell people general stats as well. So one cycle of IUI, intrauterine insemination, has about a 9% chance of having a baby. That's that. IVF cycle across all ages, and IVF pretty much very similar, but from day 3, instead of taking a tablet, we inject similarly the follicle stimulating hormone to grow not just one or two, but a number of eggs. And then on day 14, instead of putting sperm in, we actually take a woman to theatre. And of course, there's a huge consenting process, but then take the eggs out through a needle in the vagina when you're asleep. With IVF, and if you make embryos, you might make one embryo to put back fresh and then a few other frozen ones, if you're lucky, depending on your egg reserve and age and whatnot. But in a full IVF cycle, including fresh and all frozen, you can get 25 to 29% live birth rate. So you really are comparing different risks, burdens, but also success rates. And that's why with IUI, for example, I wouldn't say do it indefinitely. I would say, look, it's 9%, 2, possibly 3 cycles, but by that time you're approaching the success rate of IVF. So it might even be a strategy to go to IVF. And also, apart from a woman's age and her life goals, a really important life goal is, how many children do you want? Because if you are at an older age and you want more than one child in your ideal perfect circumstance, there may be, again, an argument to go to IVF, to freeze eggs or embryos, to fulfill what you want for your life.
So in terms of the management of endometriosis, especially when it comes to the fertility journey, and you have mentioned this previously, but there must be a requirement and an ongoing requirement for quite a significant support system. So for someone diagnosed with endometriosis, what recommendations do you have around creating a support network to help you cope with the mental, emotional, and physical aspects of this disease?
Yeah, absolutely. I am a person first and foremost, but I'm also a medical doctor. So I would say the first stop would be your general practitioner, because a general practitioner with an interest in women's health is gold, and they are able to, based on their assessment. So I'm not saying all general practitioners will do this, but if they think it is reasonable, there are things that they can do, including a chronic health plan. And that might include psychological visits with, again, a women's health psychologist who works in this space and understands the unique stresses and strains on people, on their day-to-day life, and their fertility, self-identity, just hearing about how people navigate. So GP, definitely. Okay. Then it depends on the individual, what sort of philosophy they have on life and how they approach support, friends, families, but also other support groups. And I have mentioned, say, large groups such as Endometriosis Australia. That's one you can look at their resources, their advocacy. They might even have events that might click with you. There's also government websites, yourfertility.com.au, that would have, again, clear stats on endometriosis and, I would say, validated information, just not a random website, but a website that has been made collaboratively with the government, with healthcare professionals. There are other medical specific websites or groups, such as the Jean Hales, Hailes, group, and they manage women's health. And I think there's even like Women's Health Week in September that they run and support. It depends on your level of engagement that you wish to be involved in, but some of these places are a start, certainly.
Amazing. And before we finish up, and thank you so much, these insights have been incredible. But before we finish up, from your perspective, and this, you can answer this question any way you like. What's the one thing you wish all women knew before having a baby?
Yes, thank you. I would say that the word you is a complete sentence. That life is a journey, that fertility is a journey, and we all have goals, hopes, and aspirations. Whether we achieve them or not, it's still our life. So whether we have a baby, more than one baby, no baby at all, this life is about you.
Thank you so much. That was so beautiful. I loved hearing that. And thank you so much for your time today. You've shared so generously from your absolute wealth of knowledge, and I really appreciate it. Thank you.
Oh, no, I truly appreciate your time, and the questions really strike home how we need to just have conversations. A little bit of plug about myself. I am, as I mentioned, a fertility subspecialist. There's less than 100, I think less than 80 CRAI doctors in Australia and New Zealand wide. And I particularly work in Melbourne at Melbourne IVF. I'm actually one of the clinical directors, and my main focus is education. That this is my jam, education internally for our nurses and scientists, and advocacy work on podcasts and talking to lovely people such as yourself. I also write a blog about usually public health. So about, say, the environmental factors in women's health, the environmental factors on male health and declining the sperm numbers. So that is at freezefertility.substack.com. If you want to read a bit more about my thoughts generally and further the conversation about fertility.
Amazing. And you can find all of those links in the podcast links below. So thank you so much for your time today. It's been amazing. And thank you for all the work that you do for women's health. And if you're hearing this message, I want to say a huge thank you, because it means that you've listened to this entire episode. Of course, if you have any questions about the things that we covered in this episode, or want to know more about me or my other projects, you can find me on YouTube and Instagram at The Pregnancy Process. For those currently in their conception or pregnancy journey, you can apply to join my complimentary but private community, the Preggy Training Crew. And you'll find my community application and social media links in the episode description. And of course, if you enjoyed this episode, I absolutely encourage you to share it with other women just like you. And I look forward to seeing you in the next episode.